I know this is the last talk of the day, and so what we're going to do is really just focus on the major highlights, because interferon obviously is a very important part of MPN treatment, and really what we want to do is talk about some of the things that are emerging in terms of new data, because it is sort of really exciting, even though this is a really old drug. So we'll mainly talk about the use of this in ET and PV and briefly touch on myelofibrosis. I know you've had probably an extensive lecture on all of these diseases at this point today. So the first question before we talk about specific treatments is to ask the question, why are you treating somebody? What is the rationale? And the goals of treatment really are to reduce the symptom burden in patients and to prevent the risk of thrombotic events. If we think about what we worry about, right? And physicians and patients worry mostly with patients in ET and PV about the disease transforming to myelofibrosis or to leukemia. But the reality is the most common sequelae of the diseases is a thrombotic event or sometimes a bleeding event. And so most of what we do in terms of treating and managing these diseases are focused on dealing with thrombotic events. How do we do that? Well, there's a couple of different ways. If somebody has PV, we think about phlebotomy. We think about aspirin as an antithrombotic agent. We think about lifestyle modification, which is something Anne always talks about at the beginning of the meetings, and it's supremely important, right? Things like watching your cholesterol, keeping active, not getting diabetes or keeping your diabetes under control, watching your weight, and not taking up smoking. These are all the things that are absolutely more important if you have these diseases, and so we should not trivialize that. And then finally we come to the actual treatments, and the major things we think about are hydroxyurea, or also known as hydroxycarbamide, interferon, anagrelide, ruxolitinib, and then older things like busulfan, which really we tend to only use in very elderly patients now. So that being said, who gets treated, right? We have stratifications for how we think about patients who need treatment and those who don't. When it comes to PV, it's been largely the same for some time. We put people into largely low risk and high risk categories. And someone is low risk if they're under the age of 60 and they've never had a blood clot and they don't really have any major cardiovascular risk factors. And in those patients, we really treat with aspirin and phlebotomy and really don't think about giving drugs. And then there are the patients who we deem to be high risk, and those are the patients over the age of 60 or who have never had or have had a thrombotic event, heart attack, stroke, a deep vein thrombosis, any of those types of things. And in those patients, we know the risk of having a clot is really high, and so we treat them with medications to lower their counts. The question always comes up, and it's a good one, and one that we don't have a great answer for, is 60 is the magic line. So does that mean that if somebody is 58 and doing well, that on their 60th birthday they get medication for their birthday? No, that's a conversation that for which there's a lot of gray area. And in some cases it's warranted, and in other cases we might think about delaying treatment. Now, the situation in ET used to be very much the same, that it was just those simple categories, but things have completely changed, largely due to genetics. And what we know is that patients can have a JAK2 mutation, or they can have a calreticulin mutation, or a MPL mutation. These are the three major mutations. But as it turns out, the JAK2 mutation is actually the one that is most closely associated with the risk of having a clot. And so that actually changes how we think about patients based on their genetics. So we used to have a low risk and a high risk category, and now we have a very low risk, a low risk, an intermediate risk, and a high risk category. And the very low risk patients are largely those who have a calreticulin mutation, or in other words, somebody who doesn't have a JAK2 mutation and is under the age of 61 and has never had a clot. The low risk people are those who have a JAK2 mutation but are under age 61 and have never had a clot. The intermediate risk patients are those who are over the age of 60 and don't have a JAK2 mutation, and then the high risk people are those with a JAK2 mutation and over the age of 60 or who have never had a clot. not entirely straightforward, but this is really the new way that we stratify people. And this is a relatively recent development in how we stratify patients. So that being said, let's kind of delve into the actual therapy a little bit more, specifically talking about interferon. Interferon has been used for quite some time, and there's been a number of pioneers in the field, some of whom are still active. And this is some old data from 2008 that looked at pegylated interferon, or Pegasus, in patients who had polycythemia. And what was observed and what was striking at the time was that about 95% of patients had a complete response. Let me stop and just be clear on what we mean by complete response. Complete response means that the blood count's normalized. It is not the same thing as saying a complete remission, meaning that people didn't look in the bone marrow and say there's no evidence of disease. All this means is that the blood count's normalized. So I don't want to confuse that with the idea of there being a remission to the disease. And over time, there was a sort of steady increase in the proportion of patients who responded. This is going to be an important concept that we'll come back to later, because we're actually seeing this in some of the more recent data in clinical trials. So even if someone doesn't have a response early on by 2 or 3 months, it doesn't mean that they won't. And that's what you see, is that there is a stepwise increase in the proportion of patients who do have a response. What was also observed is that the amount of the mutant JAK2 in the patient's blood actually did go down, relatively modestly, but it did go down. If we look at these patients, again, these are all polycythemia patients. The top row shows you the number of people who were getting phlebotomy. So at the start, 25 patients were getting phlebotomy out of 37, and by month 6, it was 0 out of 35. There was one patient who ultimately did need a phlebotomy again, but again, this is pretty striking that you're able to control the disease again without phlebotomy, but by just giving the interferon. So that was, one of the initial pieces of data that showed the effect of the drug. Now, we talked about the mutation, and there's this term, if your physicians might talk to you about, called allele burden. What does this mean? Well, what the allele burden essentially is the amount of the mutant JAK2 relative to the amount of normal JAK2, okay? We express it as a percentage, and in people with MPNs, it can range quite a bit. It can be, 5%, it can be 95%. And it does correlate to some degree with what disease somebody has. But the point here is that the drug is actually shown to decrease the amount of the mutant gene in the blood. What's the significance of that? I think right now the honest answer is nobody knows. Okay, we talk about this as an endpoint and we say, well, that's great, it's going down, less is better. But does it actually correlate with anything specifically? It's not clear that it does yet. It's also not clear that magnitude of decrease is important, right? There's a disease called chronic myelogenous leukemia, or CML, which is a type of MPN, which is one of the modern medical miracle stories. And in that disease, people have, a change in their allele burden on the order of, 100, 1,000-fold. And so what we're seeing here is very modest. We have to keep that in mind and not get too excited by this. Now, what about patients with ET? There have been numerous studies, and this is a list of them, or a partial list of them. And if you look at the response rates, again, response rate here is talking about normalization of the blood counts. They're really kind of cluster in that sort of 70 to 100% range, which is really impressive. And again, that tells us that this can be an effective drug for the disease. But we know there's side effects, and we'll talk about that more when we talk about the clinical trial data. But if you look at the discontinuation rate, it's not insubstantial. In some studies, it's close to 50 or 55% of patients who just couldn't tolerate it. So something that we have to keep in mind. Not everybody's a candidate for interferon, and that's part of what we have to think about when we make treatment decisions. In terms of how people have done historically who have ET on interferon, this is just a representation showing that the majority of patients, at least in this study, did have a complete response to treatment with a minority of patients having no response. And again, you can see some changes in the amount of JAK2 in the blood, mutant JAK2 in the blood. But of course, nothing in life is that simple, and we know that there are more than one mutation in a proportion of patients who have ET and PV. It's much more common in people with myelofibrosis to have more than one mutation. But if you think about patients with ET and PV, the majority, 62 and 55%, only have the one mutation, but there are patients, quite a number of patients, who have more than one mutation. Now, what's the significance of that? How does that play into anything? These are all things that a number of us are investigating on the laboratory side and trying to figure out, is there a real significance? But the question becomes, well, if the JAK2 level goes down with interferon, what happens if you have another mutation in your blood? And the answer is it's sort of all over the place. If you look here, for example, in this patient, they had a calreticulin mutation and something we call an IDH2 mutation. And the amount of the calreticulin mutation went down with treatment, but the IDH mutation didn't change. Whereas in another patient, both mutations that they had went down. And then in a third patient, two of them actually went up and another one went down. So this is something that we need to figure out. And so if one has additional mutations, I think the answer right now is we really don't know what the impact of that is, and how that changes with treatment. It's not clear what that means yet. So just by way of comparison, just so we have context when we talk about the clinical trials, what do we know about hydroxyurea? Well, it's been, I think, most well studied in PV, but also some good trials in ET. And we know that compared to phlebotomy, there seems to be less incidence of thrombosis with hydroxyurea. This issue gets raised with almost every patient I've met who goes on to hydroxyurea. What about leukemia? Doesn't hydroxyurea cause leukemia? To date, there's no large-scale evidence to support that idea. And in fact, in most retrospective studies, you don't see an increased incidence. The concern is legitimate, and it is certainly something we have to continue to look at because this isn't definitive data, but the data to date at least does not suggest that it does produce leukemia. And so it is a reasonable alternative drug when we think about how we treat somebody. In patients with ET, it has been compared to another drug called anagrelide or agrelin. And because of this data here, where it showed that there was a lower incidence of thrombotic events in patients with ET treated with Hydrea and aspirin over anagrelide and aspirin, anagrelide has sort of fallen a bit out of favor, and people don't tend to use it in the first line. And so that's why this conversation really becomes one about Hydrea versus interferon and not Hydrea versus interferon versus anagrelide. That being said, there are a number of cases where using anagrelide is warranted. So this drug kind of goes a little bit lower on the list. So again, the conversation here is really one about Hydrea versus interferon. So there's two main studies that have sought to address the question in a randomized fashion. If you have a patient with ET or PV who needs treatment and you have the choice of Hydrea or interferon, what do you do, right? We have this conversation with patients all the time when we see them, and we haven't had a clear answer. We've had all of this retrospective data that I've shown you with interferon that says, well, it works. Does it work better than Hydrea? That's the question. And so these two studies have sought to address this. One is what was called the MPD-RC 112 study. And this was a randomized study where patients who were over the age of 60 who had either ET or PV were randomized to get Hydrea or pegylated interferon. And this, the follow-up to this trial is ongoing, but this was presented about a year and a half ago, and the data from the first 12 months is available, and that's what we're going to go through. There'll be updated data presented on this trial at the American Society of Hematology meeting in December. So if we look at the responses, and here again, these are just normalization of blood values. We have the patients here who were treated with hydroxyurea and those who were treated with interferon, and this is across the entire cohort. So this is all ET and PV combined. When you look at this, the number of patients who have a complete response, their blood counts are completely normal, it was 33% in the Hydrea arm and 28% in the interferon arm. breaking it down by ET and PV, it was 44% versus 40% in ET, and 26 versus 19% in PV. Some patients have what we call a partial response, where the counts go down by a certain amount, and even then, the proportions don't change. So if you look at the overall response, which is the combination of the partial and the complete, and we look at the entire cohort, it was 69% for Hydrea and 81% for interferon, which was not statistically significant. So this is a coin flip. The data says that at 12 months, this is a 12-month readout, there's no difference in the outcome between Hydrea or interferon. But what about the toxicities? Because again, this is something we have to think about carefully when choosing a therapy for a patient. We saw more depression in interferon-treated patients. Not a surprise, this is a well-known side effect of interferon. There was more shortness of breath, more injection site reaction, which one of them is a pill, so that kind of makes sense. And there was a little bit more itching seen with the interferon-treated patients. So there are some side effects that might make you think differently about who to give what, right? And that is something that we have to keep in mind. Again, therapy has to be individualized. Now, in the PV patients specifically, if we look at the proportion of patients who had control of their hematocrits, it was 57 versus 76%, which in this study sample size was not statistically significant. So no differences there. If you look at platelet count control in patients with ET, it was 73 versus 73. So no real changes. And if we look at the patients who had an enlarged spleen, this is what we call a waterfall plot. And so when the bar goes down, that means there's been a decrease. Each bar here represents a single patient. And so in the Hydrea-treated arm, these 5 patients had a decrease in their spleen size. Two had an increase roughly. And then these patients here all had a decrease in their spleen size. So the numbers are relatively proportional. Now, one of the things that was done with this study that's a little bit different than what I've shown you before is that the histopathology was looked at, meaning that people had bone marrow biopsies and they were looked at to see, is there evidence of the disease in the bone marrow? And that's where this study differs from many other studies that have been done. And when that was done, what was really interesting is that if you look in the Hydrea-treated arm, 8 out of 22 patients had a bone marrow response, where the bone marrow didn't look the way it did in somebody who was untreated, versus only 2 out of 24 patients who were treated with interferon. It's hard to make too much of an extrapolation because these are very small numbers, okay? So it says that there is some discordance between the number of patients who have a response in their blood, where their counts normalize, and the number of patients who actually have a change in the bone marrow. That's something we have to keep in mind, okay? These are drugs that are controlling the disease. Are they necessarily changing the biology of the disease? Not clear, or at least maybe not on the majority of patients, but this warrants further study. In terms of molecular responses, we had talked about this idea of the amount of JAK2 or the allele burden. There was really no difference in the two arms. They both saw a decrease in the amount of the JAK2 mutation that was observed. Now, that's one study, and again, that is only at 12 months from the start of therapy. There's going to be follow-up data presented in about 3 months, so we'll know a little bit more. In contrast, this is another study from Europe called the PROUD-PV study. And this is a study exclusively of PV patients. And these are patients who got a drug called Ropeg interferon. This is a longer-acting interferon that only needs to be given every 2 weeks or so. And so, like the other study, patients were randomized to receive Hydroxyurea or this Ropeg interferon drug. These are mostly untreated patients who have only PV, not ET. And so if we look at the responses that we're seeing, again, these are blood responses. The number of people who had a complete hematologic response was 43% with AOP, which is the other name for the Ropeg interferon, and Hydroxyurea was 45.6%. The interpretation of the data was that the Ropeg interferon was non-inferior to Hydroxyurea. So this is not talking about which one is necessarily better. It's just saying that the interferon is not inferior statistically to the hydroxyurea. This is at 12 months. This is a representation of patients' hematocrits in red, where you see that the lines intersect. One with the open circles is hydrea, and the closed circles is the interferon, and there's really no difference in how people's hematocrits changed over time. Now, what's interesting about this study is that there was a continuation phase that followed patients up to 3 to 5 years. And here's where things get really interesting and provocative. If you look at the proportion of patients who have a response, that's what's plotted here, and you look at the green line, which is the hydroxyurea arm, people have a response, they maintain it, maybe it goes up a little bit, but then the proportion of people who have a response starts to decline around month 21. And interestingly, if you remember the first graph I showed you, remember that steep step-up curve with the interferon, how it changes over time and goes up? That's actually still what you see here. You see that it steadily goes up over time, and at 21 months, the actual number of people responding continues to increase. So this is consistent with historical data, and it shows that at 21 months, suddenly the curves have shifted. What does that mean? So last year, this group had presented some more follow-up data on the up to 24 months. So that was just added to 21 months. So what do we know at 24 months? At 24 months, the response rate for the people getting the interferon was 70.5%, and in the control arm, which is the hydrea arm, it was 49.3%. That difference was actually statistically significant. So there was a difference there. There was no difference seen in the amount of symptom burden that patients were experiencing. But again, the interesting thing is that you give it more time and suddenly the outcome switches a little bit. What does that mean? We'll talk about that in a minute. In terms of the amount of JAK2 and where it is and what happened to it, in the patients treated with hydrea, which is again this sort of off green color, it initially did go down, but then over time, people didn't have much of a response, whereas the curve is actually the opposite if you look at it in orange in the people treated with the interferon, where over time, steadily, you get a deeper and deeper response. So that is all data in first line. These two studies are talking about patients who have not been treated previously. What about the opposite, not the opposite situation, but what about another situation if you have some patient who has been on hydrea and they can't tolerate it or it's not working? Can you give them interferon and reasonably expect to have a response? Now, we know that with ruxolitinib or Jakafi in patients who have PV and have been on hydrea and start to not do well, you can give them ruxolitinib and they can have a fantastic response. And it's a durable response. The majority of patients continue to have a response to Jakafi out to at least 5 years, as was reported last year. Can we say something similar about interferon? So this was what was called the Myeloproliferative Diseases Research Consortium 111 study. And in this study, these were patients who, with either ET or PV, who had had prior hydrea and for various reasons couldn't stay on it, and so they were put onto interferon. So everybody on this trial got interferon. There were 65 ET patients and 50 PV patients. So at the end of 12 months, the number of people who had a complete response in their blood counts with ET was 43%, and 22% with PV. People with partial responses was 26% with ET and 38% with PV. So really, altogether, you're talking about a 60 to 70% rate of response in people who have had prior hydrea. Now that's interesting, right? That says you can use interferon if somebody's already been on hydrea, and you can reasonably expect to get some degree of response. Where things get challenging, as we'll talk about at the very last slide, is what's the right order of things? Does that mean they should all go on interferon? Does that mean everyone should go on Jakafi? This is unresolved. And that's okay, because I think what that says is that you have multiple paths of treatment, right? I think that's the major message. Number one, and sort of the corollary to that, is you have to individualize therapy. So it's important to know that there are multiple effective options, but you have to take everybody into account differently. There's another interesting study that was just published last year from, this is all from MD Anderson, a really nice study, where they treated people with ET and PV with interferon. And so they reported on their experience after a follow-up of about 83 months. And their responses, these were untreated patients, show that about 77% of patients with polycythemia had a complete response hematologically, and about 73% with ET. And the duration of the responses was variable, but overall it was about roughly 66 months, right? So a couple of years of response to interferon on average. But what was the reason for it not being, durable in the very long term? There was a number of different reasons that emerged. One is toxicity. So we talked about side effects of interferon previously, and certainly you do see that in the very beginning of treatment, a fair number of patients do come off in orange here due to toxicity from the drug. It doesn't actually seem to increase much over time, but in the beginning is really where you see the major signal. There's a lot of other reasons, and then people certainly do progress on interferon. I think it's important to know people can progress on any of these drugs. None of them, to our knowledge at this point, is curative, and so you do see a proportion of patients in green or in yellow who do lose their response or have disease progression and had to come off of treatment. Transitioning quickly to myelofibrosis, can one use interferon in myelofibrosis? And the answer is yes. There have been a couple of really interesting studies that have shown a couple of things. Number one, that you can see a decrease in the size of the spleen. So interferon can be used to decrease the size of the spleen. It can produce bone marrow responses in some degree of patients, and it can reduce the amount of the mutation in some degree of patients. But what most of the data seems to argue is that this effect is really limited to people who have early stage or lower risk disease. We grade we risk stratify myelofibrosis by something called a DIPSS, a Dynamic International Prognostic Scoring System. And there is a category of low, intermediate 1, intermediate 2, and high risk. Those are the 4 risk categories. The major benefit of interferon in myelofibrosis seems to be in the people who have low-risk disease and intermediate risk disease, really not in people with higher risk disease. An example of the rich getting richer, right? It benefits people who are already in the low-risk disease. The spleen response seems to be dependent on the size of the spleen. It looks, from most of the data, that if someone's spleen is over 6 centimeters, they are less likely to get a response in the spleen size from interferon. And finally, what about combinations? So there is actually this really interesting study that's combining Jakafi and interferon. And this is a study that's being carried out in Europe. The initial results were reported 2.5 years ago now, I think, where they're combining Pegasus with ruxolitinib at a dose of 20 milligrams twice daily. And this is really for patients with myelofibrosis, with polycythemia vera, or with post-PV or ET myelofibrosis. The only thing to really say about this now is that there doesn't seem to be any additive negative effects, meaning that we see some of the side effects that we know we're going to see with ruxolitinib, namely anemia, low platelet counts, and there have been some infectious issues that have gone on, things like herpes zoster, which we know from some of the ruxolitinib studies can be seen more often in patients who are treated with ruxolitinib, but there doesn't seem to be any concern in terms of a toxicity that wouldn't allow this combination to be used going forward. So we are awaiting further data from this study to see is this a viable treatment option. So final slide, and one that I don't have answers, I have more questions about, is what is the best approach to treatment? Is there a best approach to treatment? There might not be one best approach. In somebody who's newly diagnosed, should they get interferon? Should they get Hydroxyurea? Should they get ruxolitinib if there was an approval for that in the first line? Should they go on a clinical trial? Is that the best thing to do? And if they don't have success with the first treatment, then the second-line treatment, I think, is a little bit more clear, right? We have a bunch of options. It can be interferon or ruxolitinib or Hydroxyurea clinical trial or anagrelide. And here we have more definitive data, right? Because we can certainly say from trials now that have been done, if you've had hydrea and it hasn't worked, or you're having side effects from the hydrea and you have PV, you can get ruxolitinib or you can get interferon. If you have ET, you can get interferon. You can certainly also get anagrelide as a treatment. Those are all options. How do you make that decision? Again, it's individual. It depends on a given patient's other medical problems, their ability to tolerate the medication. Those are all considerations. So there isn't one set path yet, but the trials that I've talked to you about today, which are still evolving, might give us some more clarity into this question about the first-line treatment, about what might be optimal. And again, I think it's important that we give it time, right? Because the thing that we've shown today, if nothing else, is that at 12 months, the data says there's no difference. At 24 months, the data says, no, there is a difference, right? We have to give the data time to mature. That shouldn't worry you, because I think that at the end of the day, all of these things are effective and can be used effectively. And it doesn't mean if you start on one medication, you're stuck with it. We can switch to other medications, and they can still work. So the bottom line, the takeaway, is that we use the medications when it is clinically appropriate, when somebody is at a high risk of having a clot or they've had a clot. Interferon can be effective for treating ET and PV. Hydrea can be effective for treating ET and PV. Jakafi can be effective for treating PV and to some degree ET. That data is still emerging. Is one better? It depends on what you mean by better. Does better mean that you have better count control? Does it mean that the drug actually is changing the bone marrow? That part is still unresolved, right? We have to figure out what do we mean by better. And is there a right sequence of treatments? Not entirely clear yet, but at least we have some data to say how we can proceed if we have to move from one thing to the other. And last thing is there a role for combination treatments? And again, that is emerging. And it might not be just what we've talked about here. Can we think about other combination therapies that might make sense with some of the tools that we have using drugs that are in clinical trials right now? These are all open and important questions. So I hope I have not left you with more questions than answers, but if I did, that's okay.